once we look and understand where we have been, the question really most patients come to for me is, what's next? What's going on? How can we uh, improve on what we've been doing? So I don't know if you're hearing me. So I'll start talking about where do we go from here. So where do we go from here? This is a talk I love to give because you can point things out, not have a lot of data, but to show that in a program such as ours and the ones that you've seen throughout the day, we are working on other answers and other points. See, here are my disclosures. So we've talked about BRAF targeted therapy and standard of care. Where do we go after CTLA-4 anti-PD-1? And to an extent in the community, there's been an understanding that if there's BRAF targets, we can go there, or cytotoxic chemotherapy. But really limited trials in these populations, and now more is coming forward. And I'll show you some of this data in anti-LAG3 antibodies, which are other checkpoints, in TLR9 agonists, which are other ways of increasing immune sensitivity, HDAC inhibitors, completely different pathways. And then again, something you'll hear a lot about as this is coming to the fore and the data is going to the FDA, the cell, adoptive T cell therapy, using the power of your own tumor T cells to get answers. What we haven't hit on is predictive biomarkers for immunotherapy. And this is started before in the past with PD-L1. That's just looking at your tissue and seeing how much PD-L1 is there and really how that interacts with PD-1 targeted therapies. But gene expression profiling, as Dr. Sullivan and others have shown, looking at tumor mutational burden and putting these together is upcoming, where we can evaluate who can respond best to immunotherapy, who we should begin with immunotherapy, either in the neoadjuvant or the adjuvant. What Dr. Weber presented were the neoadjuvant trials. And the point there is, this is a great way to take the tissue and start a therapy, see how what's happening in the immune environment in the tumors, and then after giving some therapy, see what's going on there, what changes there are, and be able to tell you, oh, the patients that had these changes are going to respond, and then be able to utilize that from beginning to end. So where do we go from here? We've had multiple trials that are looking at attacking anti-CTLA-4 or BRAF, but now there are oncolytic viruses, direct injections into the tumor, and multiple targets where we can utilize to recognize cancer T cells, kill the T cells, release antigens so your own immune therapy can work, and then work to stimulate them through either checkpoint inhibitors, as you've seen here, utilizing IL-2, again, bring it back to the future from the data that Dr. Memi presented, and some of the other therapies. So let's go through them. What we found is that with the T cell tumor interactions, there are certain loci that come up that can be used by the tumor to get around our immune recognition and get around where we're going. And some of these are the additional inhibitory checkpoints. Now, we're all familiar now when you look at these pictures, okay, well, anti-PD-1 is on the T cell. This is where nivolumab and pembrolizumab attack. But TIM3, LAG3, VISTA, and other checkpoints can be used, bringing in interferon again. So I'll bring you to Melman's ideas about the activating receptors and the inhibitory receptors. And now more than ever, we have the ability to bring these into clinical trials. Now, 12 years ago when we began, we could only start talking about CTLA-4 and PD-1. These inhibitory receptors, when blocked, is like taking a foot off of a brake pedal, and then these activating receptors, when antibodies hit them, is like hitting the gas and moving a T cell into a hyperactive role. So this has been proven. This is Paula Sierta's data with relatlimab, looking at patients who failed, whose nivolumab or other PD-1s stopped working. And then with adding a LAG-3 inhibitor here, we've seen responses. And we've been able to understand that if you can take the tumor and stain for LAG-3 at that time, you can find those people who have higher responses than those who have lower. And this has led us to multiple clinical trials that we now have ongoing, looking at, attacking TIM3 and LAG-3. And this is a trial that we have at Angeles and other places around for patients who don't even respond to PD-1 inhibition. They're primary refractory. What do you do? We've shown that it's tolerable to bring in these other checkpoints. And now we're looking to see if we can rev up the immune system somewhat the same way that just adding one of these checkpoint inhibitors has done. As we've moved ahead, we've realized that getting these drugs to the tumor is important, and being able to utilize bispecific drugs that bring multiple checkpoints together. And this is from Jason Luke, our friend down at UPMC, who'll be leading the next same seminar. This is a drug which is bispecific for LAG-3 and PD-1. So similar to this that I just presented to you, which was 2 separate infusions, 1 drug, and the hope that these drugs can get together and that there can be greater synergistic T cell activation with this drug rather than the combination of the individual constituents. Dr. Sullivan is keying one of these trials again, and these are drugs that target other inhibitory checkpoints. It's not important to know the names. These are players, but it's important to understand that these drugs now are being looked at in monotherapy, progressing on standard care, or in dual combination with a PD-1 inhibitor. And then once we've shown that it's tolerable and there's activity, right here, a triplet combo dose escalation. And when we look here, and remember what Dr. Pirot mentioned, that melanoma is leading the way. What we have shown in melanoma in the metastatic and in the adjuvant settings has led to these drugs being introduced in the care of patients with other solid tumors, as you can see here, non-small cell lung cancer, ovarian, breast, and others. But this TIGIT target has become very significant in lung cancer in a combination with anti-PD-1. We're pushing it forward in triplet combinations. Here you can see patients who've had ovarian cancer, who failed chemotherapy, and even the most immune inactive tumors, the one on the right is colorectal cancer, showing response with these newer immune targets and newer immune checkpoints. So what does that say to me? It says, well, if you're looking for other options, it might be important to talk to your physician, your guide, your entourage of caregivers about looking for some of these therapies. Interleukin-12 is another pro-inflammatory cytokine that drives immune response. All the interleukins stimulate immunity, and these are some of the data that's been presented by our friends Dr. Dowd, Dr. Al-Ghazi, and others. You can see Dr. Ferry's name here, of direct injection of interleukin-12 into a tumor and response of patients. All of these lines going downwards are shrinkage of tumors, and here are how the responding patients have have done. And you can see these lines coming to negative 100%. So lots of patients who are responding and benefiting for extended periods of time. So there may be a subset of patients who had prior PD-1 and others, they've responded. There are others who had never seen therapy and have responded, and we'll be doing randomized trials to see who benefits. What's also important here is the understanding that these therapies don't have to just be for under the skin or lymph nodes or initial tumors that you can get at with a syringe. Here's data presented by Randy Hecht and others about a drug that's now approved for localized melanoma, Imlygic, or it's called TVEC or telimagene laheparepvec, which is an oncolytic, which is a virus that codes for an immune activator, and it's been able to show regression locally and possibly distant. But we're now being able to take these drugs and inject them directly. And if you read here, liver metastases from other solid tumors and also hepatocellular melanoma, hepatocellular cancer. And why is that important for melanoma? Well, we have seen that liver metastases restrains immunotherapy. We can't get to them. Pound for pound, the same patient who has liver metastases does worse than the patients who don't. And that's been shown through our experience with pembrolizumab. But if you can get a priming or even a boosting of the immune response by being able to directly inject immunotherapy into these liver tumors, we may be able to solve that puzzle and get better outcomes. So these trials are ongoing and coming. We have a trial here looking at an interleukin-12 construct going directly into visceral metastases like liver and other solid organs along with PD-L1 therapy. Even though interleukin-2 was approved, the understanding always was that it hit only a subset of melanoma patients, very small percentages, response 6, 10, 15%. But we're now having a huge amount of other drugs that are IL-2-like, like Bempeg or the Nectar drug, and this is already in melanoma. These drugs are manipulated in a way so that we don't have the systemic therapies of interleukin-2, that we may not need to dose high dose, and that we can be able to give these drugs that are made by multiple different companies to our patients in the clinic, even Werewolf Therapeutics down here. And this is initial data presented by Adi Diab from MD Anderson with adding Bempeg to PD-1 pathway nivolumab. And so preferentially agonizing this pathway, stimulating this pathway without getting the toxicities. And now the response rates in these early trials have looked significant. What I have been struck by is the amount of patients who get complete response, which means 100% of their tumor shrinks and goes away. And what we're really finding is this is one of the best goals to have. Now, this is early data. It is in no way to say that every patient should get this, but it is extremely interesting and hypothesis driving for us. What else? And you'll hear a lot more about this as the data gets presented in upcoming meetings. But adoptive cell therapy has been around for a long time. Steve Rosenberg has published on it, and it's only been limited to very few centers that have expertise because it requires a place where you excise, excuse me, it requires you to excise the tumor from the patient and then take it and culture with IL to grow up those T cells that are specific into billions of cells and then reinfuse into the patients with IL-2. There are now new ways that we're looking to use T-cell therapy, and this is tumor infiltrating lymphocytes. I'll talk about CAR T and others coming up. Yep. But this data showed in patients who have failed PD-1 therapy and even anti-CTLA-4 therapy, a high response rate, high durability of response, and a high disease control. I apologize for putting all of these plots in, but when you look at the right bottom plot, you see that patients get very rapid response and some have durable responses. But what's most interesting here is that the majority of patients that responded here, their previous response to prior anti-PD-1 therapy was progressive disease. All these patients got previous PD-1 therapy. 80% of them had no response initially to PD-1 therapy. So it may fit into those patients who will never have a response, and indicates the need for us to do combination trials and to improve our biomarkers to understand who will never respond, avoid giving them PD-1 therapy. That's heresy right now. We can't do that right now, but if we have the right predictive marker, we can move them onto these therapies where they can get maximal benefit early on and tolerate the therapy. CAR T therapy is where we take the patient, take out their T cells, and then in the lab, modify these T cells and expand them in, then give chemotherapy to get rid of the other immune cells that we don't need and give them these modified T cells. Now, this is standard now for acute leukemia and has shown responses in patients who fail all therapies for ALL. It's coming forward in multiple solid tumors, and this is one that's ongoing now with Anusha Kalbasi at UCLA. Well, not everyone can sit and do these therapies where they have to have tumor resected, where they have to have things drawn from them. So this is a trial ongoing where we take their cells out, the whole blood is collected, and then they're treated with TBX 4000 to activate those T cells, and then they're delivered back to the patient intravenously. And these are other ways to stimulate the T cells. Just quickly, a response from our friends at Moffitt to a patient who's failed other therapies and with T-cell therapy has gotten, a great response. And you can see here 18 months post is doing well. Even with BRAFs, there are other targets we can have. This is a drug that is a selective inhibitor of a pathway. And these are BRAF. This is a BRAF mutation patient who had tumor growth. And clearly, you can see unfortunately, brain metastases. But once on this therapy, those brain metastases and those body metastases resolve. Now, this was not a trial for melanoma, but it made sense preclinically to put patients on, and this patient has a great response. And that's just a plug for the phase 1 therapeutic programs that most of us lead in our institutes, that even though the trial does not say melanoma, that there can be some scientific rationale behind putting places onto these trials. There are newer BRAF targeted and CRAF targeted agents in combination that are coming forth. And also, as I end, some discussion about VEGF targeting. VEGF is vascular endothelial growth factor. It creates vessels that feed the tumor. This is data presented by Anna Arantz on pembrolizumab plus a drug that targets VEGF. And we've seen patients respond even post anti-CTLA-4 and anti-PD-1. This was LEAP-4. Initially for other types of melanoma, mucosal, this is from Zhang Guo in China, showing great responses in mucosal melanomas that have very low responses to initial immune therapy, but in combination have high response rates. This confusing slide says that we are now looking to combine these drugs together, whether it's a PD-1 and a CTLA-4 with a TIGIT, whether it's a PD-1 plus CTLA-4 and lenvatinib, which is VEGF. And this is looking at neoadjuvant in the neoadjuvant phase, in the initial phase, in the phase post PD-1 progression, and also now for patients with brain metastases. So triplet, doublet, etc. for brain metastases. Just bispecific antibodies, Dr. Carvajal will discuss, but just to say that it's not just for ocular melanoma as we're looking forward. Chemotherapy making a comeback slowly in other solid tumors, but antibody drug conjugates where the antibody carries the chemotherapy directly to the tumor rather than splaying it throughout your body to have side effects is looking great and is become standard in triple negative breast cancer and bladder cancer and breast cancer. And now we're looking at it in melanoma. I'll go skip through this, but also to say that there are trials now and we are looking at them. The way to read this is look at these patients prior ipilimumab, which is Yervoy, prior pembrolizumab, which is Keytruda, and now responding. Prior ipilimumab, nivolumab, and BRAF/MEK agents, and responding. And this is great data from Dr. Sullivan and the others. I did bring a prop. I told everyone to bring a prop, and they didn't. I brought a prop. This is my friend here, and it just tells you that we're now looking at utilizing our own biosphere, our own microbiota, and utilizing the way to change our microbiome, which is our poop, to get response. And there's been great data, if you're following it, about fecal transplant. You take the fecal microbiota of someone who's been responding and put it in someone who hasn't been responding, and they can now be made into someone who can respond to immunotherapy. So a lot going on there, future bright, and we look forward next year to updating you about more of these that are coming. And with that, I'll thank you for your time.